everyone, I'm Dr. Chinyere Ugorji, a 2007 graduate of American International School of Medicine with 10 years of clinical experience working as a certified nurse aide at various hospitals, long-term acute care facilities, nursing homes, with patients in their private homes, from doing my clinical rotations here in the United States, from 2 graduate medical education programs, Henry Ford Internal Medicine Residency Program, Detroit, Michigan, Springfield Residency Program, Springfield, Illinois, from various observerships and externships, and from my various preventive healthcare fairs where I've had the opportunity to have hands-on experience with a master's in business administration from Davenport University, Grand Rapids, Michigan, and research experience from UT Southwestern Psychiatry Department, working with Dr. Carol North and Dana Downs, who are both awesome people, and currently involved in preventive care and applying for residency and education on my Ustream and YouTube channel. And I want to welcome you all to Dr. Chiquito Mentoring Ustream show, where we're always learning about a preventive health topic every day. And also talking about the residency interviewing process. The show is designed to be able to help those who are applying for residency this year, and also to be able to educate the community educate the community on various preventive health topics, and also to be able to educate healthcare professionals on the various topics, on the various pathophysiology that they experience every day as they see patients in their clinics, as they go on rounds during their inpatient rotations. And every day we talk about a health topic, and this week we've talked about lots of interesting topics. We've talked about croup. That was on Monday, and we had a Powerball question that was designed to help us to read the article on my website on croup, and it was croup is more common in male than female. So I've gotten lots of answers about that on that question, and I want us to keep on getting the answers in. And then we talked about bronchiolitis, and the Powerball question was that blood culture and RSV washings is a test to be able to diagnose bronchiolitis. So I want you all to keep on I'm getting the answers in. The Powerball drawing will be done on Saturday by 12 o'clock, after which we'll do some Zumba dancing. We'll learn a Zumba routine, move like Jagger, which is actually something I've done before, and which I'm gonna do on Saturday by 12 o'clock. So today we're talking about dysfunctional uterine bleeding, and today we'll talk about what it is, how common it is. We'll talk about the risk factors, the causes, the signs and symptoms, the differential diagnosis. What else should we think about? And then also the laboratory testing. How do we diagnose dysfunctional uterine bleeding? And also, how do we treat it? What procedures are involved in treating it? And also, what important points do we need to know about it? And also, what medications are used in treating dysfunctional uterine bleeding? So I have a case study that is designed to be able to help us understand understand what it is. And it's in the office, and you have an 18-year-old girl who presents with the chief complaint of heavy menstrual bleeding. So that's the chief complaint. Vital signs: her pulse is 86 per minute, temperature 98.7, respiratory rate is 16, her height is 162.5, her weight is 55 kg or 121 pounds. So history of present illness. This 18-year-old girl presents with the complaints of irregular and heavy menstrual bleeding for the last 2 months. She started menstruating at 13, and her cycles have been regular until 2 months ago. She has been sexually active with her boyfriend for the last month, and they have always used condoms. She denies any burden on urination or vaginal discharge. She uses no medications. Her appetite and weight are normal. She's doing well at school and has no emotional stressors. The rest of the review of system is negative. Allergies: penicillin, immunization history up to date. Family history: father is healthy at 43, mother is 38 and has asthma. Maternal grandfather died of colon cancer at 60. She has one younger brother who is healthy. Social history: she does not smoke, drink alcohol, or use recreational drugs. Recreational history: attending parties and watching movies. So I'm pretty sure at this point you're thinking about a lot of things that could actually be wrong with this young lady. She has irregular bleeding. She also has um, um, just she has irregular bleeding. That's the main symptom that she has. So I'm pretty sure, I mean, at this point I'm thinking that it could be pregnancy, it could be endometriosis, it could be a cancer, it could be endometrial cancer, it could be cervical cancer, it could be uterine cancer, it could also be medication induced. Maybe she's taking some medication that is causing this problem. It could also be sinusitis, it could be an infection, it could be chlamydia, ureteritis. It could be gonorrhea infection. It could also be a bleeding disorder. She could probably have something like von Willebrand disease. It could also be due to sexual abuse. So there are lots of things that could actually be causing this young lady to have this irregular bleeding. But hopefully by the end of this presentation, by the end of this show, we should be able to know why she has dysfunctional uterine bleeding and not any of these other things that we mentioned. So I have an article on my website, and it kind of goes through most of the things that we need to know about dysfunctional uterine bleeding. So I'm gonna try and um, and and carry us along with the whole process of learning about dysfunctional uterine bleeding by going through everything that we need to know about it. So definition, what is it? Well, it's actually defined as irregular bleeding that occurs in the absence of any obvious pathology or medical condition or any other pathology. From an article written by Behara in e-medicine, it's defined as irregular uterine bleeding that occurs in the absence of recognizable pelvic pathology, general medical disease, or pregnancy, and reflects a disruption in the normal cyclic pattern of ovulatory hormonal stimulation to the endometrial lining, with bleeding that is unpredictable, excessively heavy or light, and may be prolonged, frequent, or random, and can lead to endometrial cancer in about 1 to 2% of women with improperly managed anovulatory bleeding. That's from an article by Behera 2013. So the next thing that we are going to talk about is how common is it? How common do we see dysfunctional uterine bleeding in our clinics? Well, it actually is common. It is quite common. Patients present in the outpatient setting in 5 to 10% of cases. So it makes up 5 to 10% of cases that most primary care physicians see in their clinics, and that data is actually from um, from from the article written by Behera in 2013 from e-medicine. So what causes it? Well, there are lots of things that can actually cause it. Vaginitis and infection of the vagina. Medications can actually cause it too. If you're like anticoagulation, anticoagulants like aspirin, warfarin, that can actually be a causative agent. Also, vaginal foreign body can also cause it. If there's foreign body insertion, and then also placental estrogen withdrawal bleeding. That actually occurs in the prepubertal years. That's before menarche. And that happens in newborn girls and occurs within 6 weeks of delivery, mostly because of hormones that are residual hormones from the mother. Then also contact vulvar vaginitis from soaps, bubble baths. That can be a causative factor, predisposing factor. Accidental trauma like straddle injuries from bicycles, that can actually be a cause too. Sexual abuse can actually be a cause too. Um, Then ingestion of estrogen containing products like oral contraceptives, that can also be a causative um, um, factor. And then precautions of poverty, if the patient experiences precautions of poverty before age 8 years, then they will also experience irregular bleeding. Malignancy, if they have uterine cancer, if they have endometrial cancer, that can also be a causative factor. And then also within the early reproductive years, that's during menarche, that can also be a causative factor. Menorrhagia at menarche, von Willebrand disease, that's actually a blood disorder. Another primary coagulation disorders, that's found in 19% of cases. Pregnancy-related disorders can also cause it too. Menopause, hematuria, especially if they have renal or bladder etiology. And then lower gastrointestinal bleeding like rectal bleeding. Malignancy, we talked about that. Atrophic vaginitis can also be a cause. And then also postmenopausal endometrial hyperplasia, especially if the patient is actually in the menopausal years. And then tobacco abuse can also be a problem, and also medications too. So sedative, hypnotics, antipsychotics, phenytoin, phenytoin and rifampin, and also rifampin can also be causative agents. Now, what are the risk factors? What things predispose you to have these medical condition? Well, diabetes has been known. Adolescence has been known to be a risk factor. Also, obesity too can also be a risk factor, and then also menopause can also be a risk factor. Cigarette smoking also predisposes you to having this disease. Polycystic ovary syndrome also is a risk factor too. So at this point, we'll go to the next section, and that is what are the differential diagnoses. And I would also welcome you to post any questions on my Ustream social stream on my Facebook. Any questions about this about dysfunctional uterine bleeding that we can be able to answer on this show. And then so right now we are talking about the differential diagnosis. What else should we think it could be? So like we talked about earlier, it could be vulvovaginitis, it could be abortion, it could be cervical cancer, it could be cervicitis, it could be chlamydial genital urinary infections, it could be ectopic pregnancy, it could also be endometrial carcinoma, endometriosis, endometritis, gestational trophoblastic neoplasia, hyperprolactinemia, hyperthyroidism, any thyroid disorder. And that includes both hyper and hypothyroidism can also cause dysfunctional uterine bleeding. And then thrombocytopenia can also be a differential diagnosis. Aplastic anemia, leukemia, idiopathic thrombocytopenic purpura, systemic lupus erythematosus, sepsis can also be a differential diagnosis. Other hematologic pathologies like Glanzmann's disease, Fanconi anemia, thalassemia major, acute leukemia are also differential diagnosis. Renal disease is also a differential diagnosis. Cushing's syndrome, prolactinoma, prolactinoma are also differential diagnosis. Cancer is also another differential diagnosis, and that includes endometrial cancer, ovarian cancer, cervical dysplasia, fibroids too, sarcoidosis, tuberculosis of the endometrium, and then vaginal trauma that includes foreign body and sexual abuse and laceration. And then also hormonal agents too can also be a differential diagnosis if the patient is on steroids or on contraceptives. you have to think about that, when the patient presents with this pathology. And then also intrauterine device, if they have any IUDs in, that's something that can also cause dysfunctional uterine bleeding. Herbal supplements, ginseng, ginkgo, and soy protein. Then also any neuropsychiatric medications, lithium, TCAs, SSRIs can also be a differential diagnosis. Ovarian polycystic disease, uterine cancer, and vaginitis. Now, what are the symptoms? What symptoms will the patient present with? Well, the symptoms include anovulatory bleeding, change in amount and frequency of bleeding, and that's normally due to low levels of unopposed estradiol or estrogens. And most times, the patient also has lighter and less frequent menses due to high levels of unopposed estradiol or estrogens. They also have prolonged periods of amenorrhea. They also have heavy withdrawal bleeding, and most times they also have lack of premenstrual signs. Because they don't have any progesterone, one of the hormones that also contributes to dysfunctional uterine bleeding. Ovulatory bleeding also occurs, and most times they could also have a normal menstrual cycle. They could also have a change in the amount of bleeding, and most of the changes they experience include things like menorrhagia. They describe very heavy periods and having to change their pad or tampon every 1 to 2 hours. And each tampon actually contains like 20 to 30 ml of blood. With blood clots more than 1 inch, 2.5 cm, and most times they pass over 80 ml blood per cycle. They also have prolonged bleeding. That's bleeding duration that lasts more than seven days or more per cycle. And sometimes they also have polymenorrhea. That means they have multiple periods within the menstrual cycle. So, and that actually results in shortened cycles, less than 21 days. They also have prolonged bleeding. That's only I'm sorry, they have oligomenorrhea. That means they don't have periods, or they have less frequent periods. And they also have spottings too, mid-cycle spottings. So those are the symptoms that they actually present with. So in terms of signs, what are the signs that we see? Well, yeah, in terms of signs, sometimes they have signs of compensated shock, and that includes lethargy, especially if they've bled for a long time. So lethargy, fatigue, tachycardia, tachypnea, peripheral vasoconstriction. Those are the signs that you may be able to elicit, as you examine the patient. And then sometimes they have thyromegaly. They also have obesity too. That's one of the signs that you are able to elicit. On abdominal exam, they could have peritoneal signs, especially if there is an infection involved. Also focal abdominal tenderness. On vaginal and cervical exam, which is normally done by speculum or frog-legged position for children. They have vaginal lacerations or lesions. They have vaginitis. You could also find a vaginal foreign body. You could also find a cervical polyp. And also you could also find blood in the cervical os. Pelvic examination, you could find some changes in the uterine size and also cervical motion tenderness on examination, and also adnexal tenderness or masses. So how do we diagnose dysfunctional uterine bleeding? And we are actually 20 minutes into the show, and I want to invite all of you to post your questions. I want us to get interactive on this show. It's designed to be able to help us to understand these topics that we're talking about. So feel free to be able to post your questions or any comments. Well, a urine pregnancy test is needed in any woman of reproductive age, and then also you also want to do a urinalysis to exclude any infections. And then also, if you're thinking of infections, so a chlamydia PCR and a gonorrhea PCR is also indicated too. A thyroid-stimulating hormone to exclude thyroid disease is also needed. Complete blood count is needed, and then if there's significant blood loss, then you want to do a point of care hemoglobin. That's actually a recent test that has been introduced and which actually helps in knowing exactly what yeah, of determining the extent of the bleeding. And then also comprehensive metabolic panel is also needed, coagulation profile to exclude bleeding or clotting disorders, type and cross-match to exclude transfusion disorders, prolactin level to check for prolactinoma. And then in terms of imaging, what imaging tests do we actually need to be able to diagnose this disease? Well, imaging includes transvaginal ultrasound, and this is actually the preferred and first line. And most times you find that the endometrial biopsy for stripe is more than 5 mm. So if the stripe is less than 4 mm, then cancer is actually not a diagnosis. It has a negative predictive value of 99.3. On doing the transvaginal ultrasonography, you actually may find leiomyoma, you can find endometrial thickening or focal masses. And then saline infusion sonohysterography bolsters the diagnostic power of transvaginal ultrasonography. And this actually entails ultrasound visualization after 5 to 10 ml of sterile saline has been instilled in the endometrial cavity. Then dilation and curettage is actually the gold standard for diagnosing endometrial cancer. It's actually not considered therapeutic for abnormal uterine bleeding because of the limited ability to assess the tubal cornea of the uterus. And then also hysteroscopy with biopsy also provides more information than dilation and curettage alone, and rivals the combination of saline infusion, sonohysterography, and endometrial biopsy in the ability to diagnose polyps, submucous fibroids, and other sources of abnormal uterine bleeding. So in terms of treatment, what medications do we use in treating dysfunctional uterine bleeding? Well, it's mostly caused by hormones. So, you want to use hormones to be able to regulate the endometrial pathophysiology. So most times it's estrogens, progestins, androgens are used to be able to get everything back into order. Then also gonadotropin releasing hormone agonists are also used. Desmopressin is also used. And then most of the patients experience pain, so you also need to treat that symptom. So non-steroidal anti-inflammatory drugs is actually a treatment for that. And then the levonorgestrel releasing intrauterine system, that's Mirena, has actually been shown to decrease menstrual blood loss significantly and to be superior to cyclic progestins for this purpose. Then something called mefenamic acid, Ponstel, is an NSAID. Is an NSAID, a non-steroidal anti-inflammatory drug, and it's actually used for the treatment of menorrhagia. And then androgens, like we mentioned earlier, and that includes like danazol, are also used. And then antifibrinolytics actually significantly reduce heavy menstrual bleeding. And sometimes if they have heavy bleeding, if they have prolonged bleeding, then you might actually have to administer intravenous administration. You have to give the patient an IV, an intravenous administration of conjugated estrogens, and that actually is actually a strength of recommendation of B. That's from a single randomized controlled study. Now, in terms of procedures, what procedures do we see or need in dysfunctional uterine bleeding? Well, a hysterectomy. Sometimes that's actually the last option, because after prolonged bleeding and after the effects of the bleeding, you might actually have to consider a hysterectomy. And it's a surgery to remove the uterus, and after that, which will actually lead to infertility. But then it relieves the symptoms, in most of the time. Now, how do we prevent dysfunctional uterine bleeding? That's something that is actually very important, because we want to know how to prevent it. Well, there actually there's no way to prevent it, because there are no prevention modalities. And then what other important things do we also need to know about about dysfunctional uterine bleeding. Well, a normal menstrual cycle, because I'm pretty sure you're wondering, what exactly is dysfunctional uterine bleeding? Because I mean, most people have varying menstrual cycles. Well, a normal menstrual cycle is characterized by an approximate flow of 30 ml per period, which lasts for 2 to 7 days and occurs with a mean interval of 21 to 35 days. So if the cycle lasts for more than 2 to 7 days, then that's actually dysfunctional. So and that's like abnormal bleeding from the uterus and can be characterized clinically by amount, duration, and periodicity. In terms of abnormalities, well, amenorrhea is menstruation occurring with intervals of more than 35 days. So the patient experiences less frequent periods, and that's oligomenorrhea. That also falls into the category of dysfunctional uterine bleeding. Polymenorrhea is menstruation occurring regularly with intervals of less than 21 days. So if you experience, frequent periods, then that's polymenorrhea. Then metorrhagia, that's a menstrual bleeding that occurs at irregular intervals of bleeding between menstrual cycles. That's when you have infrequent periods. You could have a period on this date and then next month you have it on a different date. Then that's metorrhagia. Menorrhagia is regular menstrual cycles with excessive flow, technically more than 80 ml of volume, or menstruation lasting more than 7 days. So when you have excessive flow, or when your periods last less than 7 days, then that's menorrhagia. Menorrhagia is menstrual bleeding occurring at irregular intervals with excessive flow or duration. So when you have irregular periods that are excessive, then that's menorrhagia. So how do we code for dysfunctional uterine bleeding? Well, coding and billing, ICD-9 is 626.6 and ICD-10 is N93.8. So that's how we code for dysfunctional uterine bleeding. So at this point, we are actually at the final diagnosis, and this patient does have dysfunctional uterine bleeding, and that's the final diagnosis. So I have a Powerball question, like I talked about, that is designed to be able to help us understand this topic, to help us be able to read this article and know more about it. And it's dysfunctional uterine bleeding is a common diagnosis, making up 5 to 10% of cases in the outpatient clinic setting. True or false? So the answer is on my webpage, and I want to invite you to take a shot at the Powerball question. You can be able to click on the link and put in your email and your contact information, and then I can be able to get that information. And then on Saturday we'll do the Powerball drawing, and if you're lucky, if you get it right, you can be able to win a prize. And I want to thank the authors of the articles that are our references. The first article is Albers J. Hall S. and Wesley R. 2004. That's from the American Academy of Family Physicians. Dr. Albers was the program coordinator from one of the programs I was in, Springfield Family Medicine Residency, which is a very strong program and which we'll be discussing later on my show. And I want to. She's a very dedicated and competent a medical educator who is devoted to graduate medical education, and I learned a whole lot working with her. And I would recommend Springfield Family Medicine Residency Program to anyone. It's a very, very strong program with lots of strengths. And the other article is from the American College of Physicians 2013. The next one is from eMedicine. That's by Behara M. And then the next one is from Family Practice Notebook. And I would encourage us to check out those articles that will give us more information on this topic, dysfunctional uterine bleeding, which is actually pretty common, especially in the outpatient settings. So at this point, we're going to go to the next segment of the show, which is the residency question of the day, and it's where do you want to be in 5 to 10 years? And that's actually a very, very important question. That's something that most programs are going to ask you as you go on your interview trails. And I have a sample answer on my web page. So I'm pulling up my slides here, and we are at the segment of the residency interview question of the day. This question is actually aimed at finding out your career plans for the next 5 to 10 years. Because after residency, you have to be able to practice independently in your community. So it's aimed at finding out, what career track, what exactly you want to do, and that's in terms of practice opportunities. And it's very important that you have a plan in place, that you are able to discuss that with the program or with the interviewee, the interviewer, and let them know what plans you have in terms of your career in 5 to 10 years. So a sample answer to this question will be, in 5 to 10 years, I envision myself in an inpatient or outpatient setting, with I'm taking care of patients with diverse pathophysiology and opportunities available in primary care, and contributing towards healthcare reform and improving patients' mobility rates. So that's a sample answer to this question. And it's because I actually, my experiences and my training, my interests are actually in primary care, and and that's where I want to end up in 5 to 10 years. It's that's why it's very important for me to be able to to get into a program that will be able to prepare me for that. Primary care is actually a growing field right now. It has a lot of opportunities. The pathophysiology is awesome in primary care, and that's why I'm interested in primary care. So at this point, we'll going to the next section, which is our feature residency program of the day, which is Jackson Park Hospital. And I actually interviewed there. It's a very strong program, and we'll talk about the curriculum, which is actually a very important part of the residency training. Well, they have 12 weeks of elective time that is found in third year, and they have various electives. But in terms of the core curriculum, for first years they actually have the orientation that takes place for 2 weeks. Then after that they have obstetrics and gynecology for 4 weeks. That's 8 weeks in general. Then they also have pediatrics, and that is made up of general pediatrics and nursery. Then they also have emergency medicine, and then they also have surgery. All of these are 4 weeks each, blocks of 4 weeks. They also have adult medicine, and then they have 4 weeks of vacation. Then in second year, they have adult medicine that includes night floats. They also have gynecology. That's 4 weeks, and then they also have 5 weeks at the ICU, 4 weeks in the ER, 4 weeks in the pediatric ER, 4 weeks in surgery, 2 weeks in psychiatry. They have 2 weeks in neurology, 4 weeks in sports medicine. In third year, they have 4 weeks in ICU. They have 2 weeks in practice management to prepare the third year residents for practice. And then they also have 4 weeks in orthopedics. And then they also have 4 weeks in eye and ENT, and 4 weeks in dermatology and research. They also have 2 weeks in radiology and procedures. They also have 4 weeks in endocrinology, and they have 2 weeks in allergy and immunology, and then they also have 4 weeks in cardiology, 2 weeks in community medicine, and then electives for 12 weeks and 4 weeks of vacation. So that's the structure of the curriculum. They have lots of didactic conferences that are actually designed to be able to help the residents to keep in touch with their didactics, to be able to get that didactic time, which is designed to help them to score high on the boards. And that includes a conference on behavioral medicine and core curriculum. Core curriculum and grand rounds. They have daily morning report and morning topic discussions. They have journal clubs. They also have case presentations, morbidity and mortality conferences, and then they have daily lectures too. It's a 3-year program, and they have 16 residents. And when I interviewed there, they actually the questions I was asked was a young patient who presented to the emergency room with mania, and we'll discuss that later on, and a child that was brought into the emergency room with fever. The program coordinator is Dr. Lakshmiya Doda, and the program director is Dr. Lakshmiya Doda, a very, very wonderful medical educator. And then the program coordinator is R. Rene Ross, and the assistant coordinator is Sharon Franklin. And the contact information is Jackson Park Hospital Family Medicine Center, 1625 East 75th Street, Chicago, Illinois, 60649. The telephone number is 773-947-7313. The email can be found on their website, and I want to encourage you all to check it out. It's a very, very strong program. I would recommend it to anyone. I interviewed there, and I interviewed and had a tour and learned a whole lot about the program, and it's a very, very strong program, and and um, and I would recommend it to anyone. So at this point, we are actually past the interview, the program, the feature program of the day, and I want to invite all of us to share our interview experiences. This is actually part of the show where we actually get to learn about our interview experiences. Where we get to swap our stories about our interviews, and it's designed to be able to help us to make sure that we have a good idea of what we want to do for the next 3 years of our life. Because residency, graduate medical education is actually designed to be able to prepare us for the next step in our career, which is being competent residents and emerging as competent physicians to take care of the needs of our community. And with that, we are actually at 8:09 right now, and we at the end of the show. I also want to talk about some of the things that we do on Dr. Chiquito mentoring preventive healthcare. We provide free healthcare. Yeah, we provide free healthcare to the community of Dallas, and that's at various community churches and also at various charity works. And also, I would welcome any community church or any charity organization to be able to invite us to be able to provide free healthcare and also home visits too to the community of Dallas and other surrounding communities. I'm also involved in education and mentoring of healthcare professionals, patient education. And then also, I'm also part of TAWAS, an American Academy of Family Physicians project designed to help adults in smoking cessation. And we actually have contacted 3 schools, where we are hoping that we can be able to get the middle school children to be be able to design posters that will be presented for at the competition at the national conference, which comes up every year in July. And with that, they can be able to win prizes. There are lots of prizes that can be won, and And I want to encourage all the teachers, all the school administrators to be able to encourage their middle schoolers. Tobacco cessation is actually something that is actually being talked about, being discussed in healthcare right now. And and then I would like school administrators to be able to get their middle school students to be a major part of this move. And with that, I want to wish you a wonderful day, and also invite you to log back in tomorrow by 12 o'clock for the complete history and physical examination, and also our preventive health topic of the day, which is septic arthritis. And I want to wish you a wonderful day.